The English version. The image that we see here in the New England Journal is a computerized tomograph showing the coronary arteries in a 47-year-old man who presented to the cardiac clinic for he doesn't even have any symptoms, this person, but he has a past history of IgG4 related disease. View here is apparently an incidental finding, I suppose. At any rate, we're asked what it is. And what he has is he has an aneurysmal dilatation of a coronary artery. And we're offered amyloidosis, IgG4 related disease, coronary artery disease, giant cell arteritis, and Takayasu's arteritis. I'm not aware that, and there are 4 different classes of immunoglobulin. They are produced by B cells in response to viral diseases and bacteria. And the immunoglobulins of the G class differ in terms of their hinge region. That's this business here. And IgG4 shows this particular configuration compared to the other IgGs. I'm not really knowledgeable enough about them to give you more details. But at any rate, these IgG4 associated diseases are fibrotic conditions like autoimmune pancreatitis, cholangiopathies, retroperitoneal fibrosis, fibrosing thyroiditis, and sclerosing mesenteritis and tubulointerstitial nephritis. So this list doesn't even include the heart. The clinical findings, the eye can be involved, and here the thyroid gland and submaxillary glands shown here. These patients not always have an increase in IgG4 levels. So having a normal IgG4 level does not exclude this diagnosis, and what's necessary is a biopsy that's stained for IgG4. To be perfectly frank, I'm not quite sure what the physiological role of IgG4 is, and I couldn't find clear indications in the literature, although these fibrosing conditions are now well appreciated as being somehow related to IgG4, and the treatment is immunosuppression. Steroids are the drug of choice. So here's a quick review that I found in German. Pituitary gland, thyroid gland, lung, biliary tract, prostate, lymph nodes, pancreas. This lady is obviously an expert on this condition, and we can use some PET kinds of imaging to show these diseases, but even in this list, the heart doesn't show up. So I'm curious what the story will be next week to tell us about this. The next topic in the New England Journal involves a neuromuscular blockade. And in this case, it's by a competitive blocker, such as D-tubocurare, which Indians in South America used for their poison-tipped arrows and blowguns, etc. This is a competitive inhibitor of the acetylcholine receptor, and derivatives of this poison have been developed to provide for neuromuscular blockade. And the drug that we're going to talk about today is cisatracurium, which is medium fast. So for immediate neuromuscular blockade, we looked at these options some weeks ago. Succinylcholine is commonly used, but it causes depolarization distal to the acetylcholine receptor, which these curare-like drugs do not. The topic is acute respiratory distress syndrome. This is an acute example of lung failure, non-pulmonary cardiac edema. There are numerous causes: shock lung, smoke inhalation, infections, aspiration pneumonia, and conditions. Fat emboli is another example, and there are criteria how this diagnosis is made. So here's some röntgenograms. This is actually here a lung biopsy, obviously, and the criteria involve the partial pressure of oxygen in arterial blood compared to the FiO2. And in this particular study, the hypothesis was tested that early neuromuscular blockade with obviously deep sedation of these patients might lead to a better end result than a more conservative sedation and less neuromuscular blockade. This hypothesis had been tested earlier in a smaller study suggesting that early neuromuscular blockade and deep sedation would result in better outcomes. So in order to look at this more carefully, 500 patients were randomized here. They had a PaO2 to FiO2 of less than 150. If you're quick on your mathematics, you'll realize that the normal would be 500. So these patients are quite ill, and they were randomized. These patients were intubated and required mechanical ventilation, which is generally the case in patients with acute respiratory distress syndrome. So here's the assignment, and the neuromuscular blocking drug that was used here was cisatracurium, and for almost 5,000 patients were looked at to successfully randomize 1,500 to each group. And if we look here, the group that got light sedation that's the control group shown on top. The intervention group was given deep sedation, and then the sedation was gradually decreased over a period of 7 days. And it seems like the randomization was successful. But if we look at outcomes, survival, discharge from the hospital, or discharge to home, survived the hospital or discharged to home, there was absolutely no difference in the groups. So the outcome of this study really doesn't suggest that early neuromuscular blockade and deep sedation provides an advantage for these critically ill patients. There are possible reasons for this. They're discussed by the authors, why this outcome was different than the smaller, earlier study. Might have something to do with the amount of positive end-expiratory pressure that these patients needed and other possible explanations. But on the whole, it doesn't really look like deep sedation and early neuromuscular blockade provides these patients with some sort of an advantage. The next two papers have to do with asthma, and asthma is an acute reversible bronchospasm. The classification of asthma is complicated, and different classifications are used. We used to divide asthmatic patients into extrinsic asthma and intrinsic asthma. The extrinsic variety is more associated with allergies and more likely to exhibit high amounts of eosinophils and Kirschmann spirals in the urine, etc. Rubbish. Kirschmann spirals in the sputum, etc. There are bronchiolar changes that obviously occur with asthma, and last week we talked about mucus production, etc. So there have been substantial advances in how we treat these patients with modern inhaler therapies that mostly rely on the inhalation of corticosteroid derivatives, short-acting beta agonists or long-acting beta agonists, and also ipratropium and drugs of this nature. Now, in this first study, the issue is patients that have asthma that have a low eosinophil count. And we've looked at asthmatic studies in asthmatic patients with high eosinophil counts, and there are various strategies to combat eosinophils, and I've outlined them here. They are not a part of this paper. Here we have to do with, more commonly, patients that have low eosinophil counts. And these patients had relatively milder asthmatic episodes, and they were randomized to several treatments. One is inhalation with a synthetic glucocorticoid. Another group got tiotropium, which is a long-acting muscarinic antagonist, and a third group got placebo. And the primary endpoint in this study was a hierarchical composite endpoint looking at treatment failure, asthma controls, and FEV1 after a given period of time. And the secondary outcome was sputum eosinophils, but I would assume that those levels had to be low than the patients, because the patients that were enrolled in this study had less than 2% eosinophils in any event. So it looks like these patients have fairly mild asthma. Their FEV1 is 92 and 89% respectively, and other parameters that we can look at here, age, duration of asthma, etc., is similar in both of the groups. And if we look at the outcome here, the steroid outcome compared to placebo indicates that mometasone is better than placebo, but similarly, tiotropium was also better than placebo. And if we look at a comparison, it looks like tiotropium beat placebo more than the steroid compound beat placebo. At any rate, the conclusion reached by the authors is that one of equipoise. This is a modern buzzword which seems to suggest some equivalence. At least the results of the study suggest that patients with mild asthma and low eosinophil counts might do as well with tiotropium as compared to steroids, and that then side effects of steroids could be avoided in these patients. That's basically the conclusion. The next paper also involves asthmatic patients, and there were two principles that I didn't appreciate that much. One of them concerns actually a protein that was first discovered in bone as a bone matrix protein, and this protein is periostin. And I learned that periostin is involved in the pathogenic process, how eosinophils mediate their reactions, and periostin was measured in these two groups of patients. And so I wanted to draw periostin to your attention. The other variable that was measured here is expired nitric oxide. And this is a technique that's used to evaluate asthmatic patients. And the expired nitric oxide is expressed as the fraction of exhaled NO. So FeNO was one of the variables that was measured in this study. And there are new devices that can be applied so that patients can monitor their own nitric oxide excretion. Now, one of the drugs that was used in this study is budesonide, and I show that here. Budesonide is a synthetic corticosteroid. It's metabolized by the same CYP450 enzymes that also metabolize oral contraceptives, so we have to be aware of that, because in female patients that ingest oral contraceptives, they may have to adjust their dose or choose some other method of contraception, just as a background information. And these patients also had mild asthma, but they were not stratified on the basis of their eosinophil counts. And the treatment here is fairly complicated. As a background, the patients had an as-needed short-acting beta-2 agonist. Terrible abbreviation, but these are called SABAs. So there are three groups of patients here. And one patient group got albuterol. 2 inhalations from a pressurized meter dose inhaler is needed for synthetic asthma. That was the albuterol group. Another group got budesonide, and these patients also had plus as needed albuterol, so this was the budesonide maintenance group. And a third group got a combination, an inhaler that includes both budesonide and formeterol. And the primary outcome was annualized rate of asthmatic exacerbations. And so periostin was measured in these patient groups, and the periostin concentrations in all three groups was the same, and basal FeNO values were also the same. So here we go. And what we see here is that the two budesonide groups were better than the albuterol alone group. And we can look at the FeNO values, and they also decreased in the budesonide groups compared to the albuterol alone group. And that's basically the point. I think that these inhalers are a substantial advancement in the treatment of asthmatic patients, and we can adjust the inhalers according to these randomized controlled trials for the best possible outcomes in these patients. So budesonide-formeterol and budesonide maintenance beat albuterol alone, but looking at it critically, it looks like budesonide-formeterol was superior to the other two groups. So you can advise your patients accordingly. The next topic at the New England Journal is what do we do with premature newborns with respiratory distress? And I suppose the answer to that question is hopefully as little as possible. The least invasive form of treatment that we could give them is nasal high-flow oxygen therapy. And the next step would be CPAP, or continuous positive airway pressure. Neither of these infants looks very happy, but this is less invasive than that. And both are less invasive, obviously, than getting intubated and getting put on a ventilator. So the investigators in this study reasoned that nasal high-flow therapy might be as good as CPAP, and that nasal high-flow therapy might be sufficient to treat these newborns that have some respiratory distress. And as we see here, these little babies are pretty sick. pH 7.2, PCO2 is 65, and the amount of FiO2 that they got was the same in both groups. So these young infants have respiratory distress. Their gestational age is, they're premature at 36 weeks. APGAR scores aren't too bad, I think, 8 in both groups. And other characteristics are shown here. Now the outcome is treatment failure, having to get put on a ventilator. And if we look here, this outcome occurred more commonly in the high flow group than CPAP. So it looks like CPAP beats high flow, but then high flow might be sufficient at least for some of these infants. And what the authors here discuss is that not a totally negative study. High flow wasn't as good as CPAP, but perhaps this gives pediatricians a hierarchy of treatments that they can offer these kids. In other words, high flow, then CPAP, and then, if necessary, intubation and ventilation. The review in the New England Journal has to do with a global elimination of chronic hepatitis. And as we have discussed before in this round, we're now in a position to do that. And if we look at this, the point here is hepatitis B and hepatitis C infection, and these have continued to increase. Although AIDS peaked in 2006 and is now going down, malaria is going down, and the projections to 2040 are a great improvement. Tuberculosis, despite the papers that we look at, is getting better and is going down, but hepatitis B and hepatitis C infections are going up, even though we have effective treatments for these conditions. And that's basically hardly excusable, since these things could probably be eliminated from the planet, and that's discussed here. Hepatitis B vaccination can now be offered to infants, which should in essence, eliminate hepatitis B. And hepatitis C can be reduced substantially by prophylaxis in terms of needles and syringes and this sort of thing. And then there are effective drug treatments to eliminate hepatitis C. So it's inexcusable that we can't reach a 2030 target to eliminate these forms of hepatitis, because we can prophylactically avoid them, we can treat them, we can suppress them at least, and there are a variety of strategies that can be applied here. Some of these have been applied already. For instance, in this term is microelimination, eliminating hepatitis B infection in certain populations, and that's been achieved in Alaskan natives through a comprehensive hepatitis B infection program, and these things could be extended to other populations. Now, last week we looked at this barium. It's a barium enema, but it's a soluble contrast material. It looks like a question mark, but it's not a question mark, because the answer is Hirschsprung's disease. And this youngster was operated upon with the operative procedure as outlined in this case report and did better. The next little report from the New England Journal is a 2-year-old girl that had some wiggling things in her stools, and it turns out they were worms. And looking at these entities, in essence, what's seen here is these are proglottids filled with eggs from tapeworms. And we need to keep in mind that our pets can be infested with tapeworms also. And this 2-year-old girl had probably gotten this infection from the family cat. Now, the patient in the New England Journal is this 53-year-old man who is of East Asian extraction and travels there frequently for business reasons. He has heart disease, but I don't think the heart disease is really related to his current problem. His heart disease is severe enough that he's got this defibrillator built in here, but at least in terms of his chest x-ray, he doesn't seem to be in heart failure. Now, his problem is cough and sputum production, and blood sample is obtained, and he has a fairly substantial eosinophilia. And that's basically the clinical challenge here, is what can cause eosinophilia in an Asian man who travels there frequently. And in Germany, the first thing I would think of would be Church Strauss, but that's not the answer here. Because, we're given his electrocardiogram. It really looks pretty good. He's got sinus rhythm at least, and there are some not very specific T wave changes shown here. And then we look at his eosinophil count, it's fairly brisk. He's got 30% eosinophils. And that's high enough that we have to consider what's the differential diagnosis of massive eosinophilia. And even certain malignant diseases would play a role in this part of the world. But if we think of worms, what would occur to me would be helminths, strongyloides, echinococcus, schistosomiasis would cross my mind, but well, I guess he could have schistosoma mansoni. So these things are looked at, and he's got antibodies to strongyloides, but no strongyloides can be found. Paragonymous, the lungworm, was also considered, but it doesn't have antibodies to paragonymous. Now, he doesn't have pneumonia, so he doesn't really no infiltrates here, so he really doesn't qualify for Leffler's syndrome. But Leffler's is a form of eosinophilic pneumonia that occurs during acute larval migration. So non-infectious causes of eosinophilia are discussed by the expert. Also allergic bronchopulmonary disease, aspergillosis, and things of this nature. But the focus here is on parasites. And what parasites could this be? And this wouldn't have occurred to me either. But filarial parasites play a role here. Now, he doesn't have elephantiasis, so it doesn't look like Wuchereria bancrofti, but there is a filarial parasite that occurs in Southeast Asia called Brugia malayi, and he's got antibodies to Brugia malayi. And the question is, how do you get blood samples to try to find these parasites? And the trick is that you have to get the blood samples at 2 o'clock in the morning, because these parasites don't travel around in the bloodstream all day long. They're nocturnal. And so you have to get up in the middle of the night to get these blood samples to find these parasites. So then the treatment here, I think, is very interesting, because it turns out that this particular parasite has a commensal inside him. And this is a bacterium that the parasite needs to thrive. And this bacterium is called Wolbachia. And so you have to first eliminate Wolbachia. And you can do that with doxycycline, which was done here. And after the doxycycline treatment, then the parasites are weakened, and then they respond to diethylcarbamazine. So those are the pearls on treating Brugia malayi. And here's the life cycle event that this parasite, as is Wuchereria, is transmitted by mosquitoes. And then the human stages, the darn things make home in the lymphatics, and Brugia malayi seems to like the lungs. That explains the respiratory manifestations this patient has. And then the production of microfilariae, hopefully looking for a mosquito to transfer the disease further, but our patient was treated. Here's a short question from the New England Journal. It concerns a 21-year-old man that clinically has impetigo. And impetigo used to, at least in my generation, almost always be beta-hemolytic streptococci, and we treated the condition with penicillin. But penicillin isn't even offered anymore. So the answer here, I would have thought maybe doxycycline would work, but the answer that the people wanted here is this ointment, mupirocin ointment, which is used for methicillin-resistant staphylococci also. But I think streptococcal disease is still important here, and these patients with impetigo are at risk for getting post-streptococcal GN, incidentally, but that wasn't discussed here. The next topic is status epilepticus. I thought I reviewed that. Must have. All right. Status epilepticus means people that have a grand mal epilepsy, and you do your best to treat it with lorazepam or benzodiazepine, and after 20 minutes they're still seizing. And the question is the new drug, levetiracetam, better than phenytoin, which has been around since 1930 and was a substantial advance for the treatment of patients with grand mal epilepsy, although now more modern drugs have less side effects than phenytoin. But for status epilepticus, phenytoin is still in use. And so this randomized trial, this is status epilepticus in adults now, they were randomized after meeting the criteria for status epilepticus. They were randomized to an infusion of phenytoin compared to an infusion of levetiracetam. So if we look at these patients, men and women, fairly older, tonic-clonic seizures, seems to all fit. I was looking for what drugs they were given initially. Lorazepam would be the drug of choice in Europe to try to break the seizures, but apparently these patients didn't respond. But what we see here is phenytoin was at least as good as levetiracetam for stopping grand mal epilepsy in these patients. And in terms of adverse events, I think the drugs were also, if we look at the percentages here, I don't think that there's anything significant here. So the old drug is as good as the new drug. Although I think if this treatment had to be extended chronically, I'd rather have the new drug than the old drug. Oh, here's a little review on status epilepticus. Still seizing after 20 or 30 minutes. The drugs of choices in Germany, at least, are lorazepam, but physicians commonly give midazolam, but it's short-acting, and so 5 minutes after the dose, the patients may begin to seize again. Lorazepam at least gives you several hours. Don't bother to order an EEG, but if you do, it might look like this. Next study, same hypothesis, but now we're talking about children instead of adults. And here the children were randomized to phenytoin infusion compared to levetiracetam. And the outcome was how long does it take to stop seizing? And these kiddies got midazolam as first-line anticonvulsant, and they got it by various routes. And as an end result, here, if we look at these results, I'm trying to find a graphical display, but apparently wasn't a graphical display in the study, but it looks like phenytoin did pretty well compared to levetiracetam. This is safety outcomes and death, respiratory, cardiovascular events, not significant. So no significant differences in the safety outcomes. But here the authors also discuss the possibility of instead of maybe the question is what's better isn't the relative question. Perhaps we should give one drug, and if it doesn't work, then give the other drug. And maybe a tandem treatment would be a better approach to treat these patients. The next is a report from Kenya. Are they making progress in 10-valent pneumococcal conjugate vaccine? A great advance in medicine, in my view, in the last 10 years has been vaccines against pneumococci, which should probably be given across the board to all humans, but certainly to older people my age. But it also is important for children. And if we look at here how the Kenyans are doing on vaccinating their patient population, actually looks pretty good. So they're getting the infants vaccinated. That means the number of people that are vaccinated between the ages of 5 and 9 and is gradually improving. And the incidence of acute pneumococcal events is also going down, as this graphic display shows here, which means that the vaccine is important. So if we look at pre-vaccine, I think this is extremely impressive. If you look at the pre-vaccine era compared to the post-vaccine era, these episodes of severe pneumococcal infections have decreased dramatically since the introduction of this vaccine. And if it works in Kenya, it'll probably work in Germany and the United States as well. So, good news. The review is, I don't really know why this topic needs to get reviewed, because this concerns aspirin and the primary prevention of cardiovascular disease. And we've really known since the end of the 1980s, when the FDA decided not to recommend aspirin as a primary prevention, this doesn't help too much, despite Bayer's active advertisement. So in 1989, the FDA did not recommend aspirin for primary prevention. And this recommendation was repeated in 2003. And in 2014, same news. So I really don't know why the topic needed to be reviewed. And every study that's ever been done looking at this issue is reported in this table. And then the table is even continued on the next page. But the end result is we have little evidence that as a primary prevention, Aspirin helps to prevent cardiovascular disease. Secondary prevention, yes. Primary prevention, no. So I don't take aspirin. And that's about that. So in conclusion, aspirin does not reduce fatal cardiovascular events in patients who have not yet had a first event, but it does increase the risk of bleeding. And I know all about that, having experienced that. So keep working on it, friends at Bayer. Another review in the Lancet is, this is remarkable, immigrant health. Challenges for immigrant health in the United States, the road to crisis. I think one of the things that we don't appreciate is that the United States is actually harboring more immigrants than any other countries, more migrants, 46 million out of a population of 300 million. So this is a major problem as people are entering the United States for a variety of reasons. Some because they're politically oppressed, but most for economic reasons because of the massive population explosion happening in Central America and climate change and things of this nature. And this is also an issue for Europe because we have to figure out some sort of policies have to be put into place in how to deal with this problem constructively in the United States, but also in Central and South America, where the problem reigns. And at least in the US, this problem has not been addressed in the last 50 years. So Donald Trump is addressing it, probably ill-advisedly, and perhaps better strategies could have been done. So that's discussed in this review, how US policies work. There's little evidence that European policies are better. And separating children from their parents is a dumb idea, but I think we all appreciate that. So the last report is this one. Dog licks baby. Baby gets Pasteurella multicida meningitis. And the case report involves a 12-year-old baby that's admitted to the hospital with fever, irritability, and poor feeding. And whether or not the fontanelles are bulging is irrelevant. If you can't figure out any reason for why this is happening, a lumbar puncture is probably indicated. At least that's what I was taught. So a lumbar puncture was done. And it shows proteinuria and lots of white cells. And then you would think in a 12-day-old baby, it probably would be Haemophilus influenzae, but it was Pasteurella multicida. So where did that come from? And there are the two culprits, the Maltese poodle and the Bichon Shih Tzu. Cute, aren't they? But maybe pets should not be allowed to show such affection for a newborn baby. Thank you for your attention.